This is Deborah Atkinson, and you're listening to Flipping 50, where I address your top questions and struggles. I share what to eat, how to move, and think to get the energy and vitality that you want in this second and better half. So welcome to our show today, and I have a confession. I've shared this in the green room with my guest today that I'm a little nervous. So even after 34 years and 5 years of podcasting, when I have a guest that I highly respect, who puts out content that is extremely valuable, and I feel the topic is something that will be valuable to you, I too get nervous. My guest today is Stuart McGill. He's been a professor of spine biomechanics at the University of Waterloo for over 32 years, authored over 240 scientific journal papers, and has mentored over 40 graduate students during his scientific journey. As a consultant, he has provided expertise on low back injury to various government agencies, many corporations and legal firms, and professional international athletes and teams worldwide. He is regularly referred special patient cases from the international medical community for opinion. And I'll mention that Dr. McGill is also the author of Back Mechanic, which is actually written for you and guides you through a self-assessment of pain triggers and shows you what to do and what not to do. It's an excellent resource for your home use. Dr. McGill, welcome.
Thank you so much, Deborah. And I was just listening to your confession at the outset, and I'll tell you something. I've been doing this for well over 30 years as well, and that little nervousness never goes away. There's such a burden of this feeling of responsibility to get it right, to help people, and anyway, I hope we pull that off today.
I hope so too. And this is such a hot topic. I mean, I think all of us know someone, if not ourselves, with back pain. We also, know how important core strength and stability are. Many of the women in my audience listening right now, core stability may not be what they say to me when they ask for a flat belly, but it is probably a part of getting there. So I have a question. So one of the reasons that I am so familiar with you, that you come so highly respected and recommended among all of my colleagues and peers, is that I was thrown off of a horse before graduate school and had a pretty severe injury that took me about 4 months to get just back on my feet. And, at that point, I certainly didn't see it as a blessing. I do, for the years and decades that followed, realized that it made me far more aware of a depth of knowledge about core care and about back pain prevention than I ever would have gained otherwise. But what about you? What actually led you to low back injury being the topic, the one thing that you dive deep into? Was there a personal story there?
There really wasn't. And this will be a bit disappointing for you. I was doing a master's degree in biomechanics at the University of Ottawa, and I was playing with the professor's hockey team, and we happened to play the University of Waterloo. And after the game in the dressing room, the two teams usually have a beer together. And this professor, who I knew a little bit about, but we just started to talk, and it happened to be a fellow named Bob Norman from the University of Waterloo. And he said, "I'm just starting spine mechanics at the University of Waterloo. Why don't you drop by the lab and have a look around?" And I was going to the University of Waterloo thinking about systems design engineering for my PhD. But when I met Bob and went to his lab, I switched. So that was really it. I wish it was more exotic than that. But then a very interesting thing happened. Obviously, not being trained as a medic, but rather as a scientist, we would work to try and figure out how the spine worked and the mechanisms of pain and dysfunction and those kinds of things. And then I would get invited to different medical meetings and orthopedic meetings, neurology, etc. And the docs in the audience would say, what you just described in terms of mechanism is not the way we think, but that might be very relevant to a difficult case. Would you come and see this patient with us? And I would say, well, no, I'm not a clinician. But they talked me into it. And I realized very quickly that the way we looked at the interaction of variables in what created the pain mechanism was unique and different. And I became quite comfortable quite quickly with patients in doing really quite unique assessments and actually provoking their pain and symptoms. So we confirmed their resiliences and their mechanistic pathways of pain. And then we were able to show them almost immediately what they can start to do to wind down the pain sensitivity. So, and after that, I would just have to say it's my personality. Whatever I get into, I try and understand how things work. It's just the way my brain thinks. So that's the story. It's not very, there was never, I can tell you one thing, my high school teachers would never have said in a million years that Stu McGill was going to be a professor of spine biomechanics.
Okay, well, you've actually teased some content here already. So I love the piece of hope in that, you're talking about provoking the pain to pick up clues essentially and, solve it. And I'm suspecting we're going to go deeper here, but let's talk about the myths and do a little myth busting. What are the ones you see or hear most often?
Yeah, well, I don't see the average patient with back pain. I see the more challenging cases, those who've tried other forms of therapy and have failed. And usually they will come and say, I've tried everything. All I have left is surgery. And I'll say, no, you haven't tried everything. That's a myth. You have never had an assessment yet that reveals the mechanism of your pain. And when you get that assessment, you will know very precisely what to stop doing to allow the pain to desensitize, and then what you should do to build the foundation for pain-free movement. So that's a myth. They've tried everything and they've got nothing but surgery left. It just means they've never had an assessment. Another popular myth would be, I've had an MRI that showed X, Y, Z. Well, and therefore that's a justification to have something corrected by a surgeon or whoever. Well, the funny thing is this, an MRI is simply a picture. And what it shows is both the wound and the scar. So let me give you an emergency room analogy. If a person walked into the emergency room with a massive cut and bone sticking out or whatever, the emergency physician would assume that that's the thing that they have to attend to. But if the injury was 20 years old and there'd be quite a nasty scar there, that too would show up on the MR. They both show up as the same. So when a radiologist looks at an MRI scan, they are seeing both the wounds and the scars of the spine. Some might be fresh, some might be 20 years old. So then some people interpret that as saying, well, MRs aren't very useful and they're not linked to pain. Well, they're not very useful when the radiologist has never seen the patient to give them context for the evidence that they're seeing on the MR. But when you look at those MRs within the context of the patient, now you have much more information that is useful. So be careful with just reading an MRI report and using that as a justification. You often hear that an MRI, if you want an excuse to have surgery, go get an MRI. Well, that's a bit dark. but the use of the technology is a bit abused, I'm afraid. The next myth might be, back pain is a life sentence. Well, not really. And your audience, being over 50, will probably enjoy this next myth. Most of them will grow out of back pain if they had it in their 20s, 30s, and 40s. Most of the time, that pain will be discogenic pain emanating from dysfunction of the discs. Either they flattened the disc with a little end plate damage, or they've got a bit of a disc bulge or whatever. But nature will stiffen up that disc, and so that genesis to their pain will slowly disappear. And you don't hear of 70-year-olds complaining much about back pain, at least that particular type. They'll say, I had that pain when I was 40, but it went away. But the 70-year-old and upwards tend to get more of the stenotic categories of back pain from arthritic bone or hypertrophied facet joint capsules that make the space that the nerves travel through, excuse me, a little bit tighter. So they get stenosis symptoms. For example, when they walk, it causes pain, yet when they sit down, that's relieving. Whereas when they were 40, the discogenic typical pattern would be sitting down at the computer causes back pain, but going for a walk for a couple of kilometers is very relieving. So do you see how the pain changes? And
definitely, yeah.
And then if we get into stenotic categories of pain for older listeners, again, there are many different subcategories. Some do very well with an extension pattern, if you can think of this, because it's very common to tell a stenosis patient, if you're walking and that causes back pain, don't walk, go ride a bike and be flexed over through your spine. Now that might work with a good proportion of stenosis patients. And yet that also keeps some stenosis patients symptomatic. Whereas instead, let's say they can walk 5 minutes before the pain becomes problematic. Don't go and walk 5 minutes. Walk only 4, and then walk up to a bench, say if you're walking in a park, up to the back of the park bench, put the heels of your hands in front of you on the top of the park bench, bring your shoulders up over your hands and carry weight down your arms. So you're actually going into a slight traction with your spine, and then allow your hips to drift towards the back of the park bench. So it's a traction extension strategy. And people will be surprised at how often that is relieving. And now when they stand up, they say, my symptoms are now gone, and they can walk for another 4 or 5 minutes before the symptoms start, and then they repeat what we call the park bench decompression. So if they did that 4 times, for the first time now, they've just had 20 minutes of interval pain-free walking. And slowly they can build that up and regain their ability again. So it's just another example of how there's no such thing as generic back pain or specific back pain. An assessment will always reveal that back pain is specific and back pain has a cause. And when you are savvy to that, how liberated you are now, or empowered you are to take control and know what to do and what not to do. So there's a few myths that I hope most people will find very encouraging.
Very insightful. Yeah, and I love that. That was definitely, you beat me to the punch. So my question was, gradually that 4 minutes could become 5. You're going to see that kind of expand so that they're able to do more walking at once before the pain comes, correct?
Yes, in some people, they will completely regain their walking ability. In others, they will regain partial ability, and in others, it will make them worse. So again, the assessment will reveal whether or not that was the appropriate strategy for that particular mechanism.
So you've alluded to this a little bit with some of your myth busting a bit. What do we do about back pain? specifically?
First of all, there's no negotiation on this. You have to have a thorough assessment. But here is the roadblock, and it's systematic in the medical system. The typical scenario would be you would wait a number of months and get a consult with a surgeon or a back pain specialist, and you're lucky to get 10 or 15 minutes, and they may not even touch you. There is no hope to reach a precise diagnosis of your back pain. So in lieu of that, of course, when I see a patient, I see my assessment lasts about 3 hours to go into the pain provocation series. I just simply talk to them. Sometimes it might take half an hour. And for the first time, I'm learning what were the impediments as to why previous attempts to get their back better failed. The stories I could tell you, but I'm just thinking of one particular person at the moment. They said, well, we know that we were supposed to do this interval walking for our back, but we live in an unsafe we live in an unsafe neighborhood and we don't feel safe going out at night. So what do you think their adherence to their walking program would be? It was 0. So when you learn that, you can then create alternate strategies so that you can systematically remove the impediments that caused them to fail in the past. And then once well, as I said, they have to get this assessment. Well, short of coming to an expert in assessment, that's why I wrote Back Mechanic. It guides the reader through a self-assessment of their back triggers. So that starts with specific motions, postures, and loads. They write down in columns what makes them better and what makes them feel worse. And then we guide them through how to analyze what the common elements of those two lists are. And then they do a few self-tests and further increase their understanding of their triggers. And then we give them a loose subcategorization. And then we say, well, for this subcategorization, chances are you will do better by tying your shoes with this half lunge versus sitting down on the bench and bending down to tying your shoes, because one of those forms your pain trigger and yet the other one alleviates it. Then we get into the principles of spine hygiene. So we show people how to move in a way that doesn't cause back pain. That is the critical first step because it's essential to desensitize the pain triggers. Can you imagine someone having a sore thumb and the doc says, oh, here, do these thumb exercises? Well, wait a second, my thumb's already sore. Doing more exercise will increase the sensitivity of my thumb. But if they said, let's stop moving your thumb and let it settle, let it desensitize. That's what we do with backs. And then we figure out what are the variables that need to be enhanced with exercise to build the foundation that person needs to become pain-free in the best case, but certainly less pain in not the best case. And then once we do that, we show them forms that are really non-negotiable. The body is made to walk. It's very difficult to have a healthy spine for someone who doesn't walk. So get out of the chair, and we usually recommend 3 walks a day. Mealtime is probably best. Then we show specific patterns of movement, a pulling pattern, a pushing pattern, a pattern for carrying. Now, I guess most of your listeners won't be picking their own children up out of the crib, but they may be having to pick their grandchildren up out of the crib. How do you bend?
Well, it is 2017, so there are some of us who still have a 5-year-old.
Okay, fantastic. But how do you pick up that 5-year-old? So we go into the mechanics of all of those things in spine-sparing, appropriately spine-sparing ways, because clearly we don't want to spare our spine all the time. It needs work to thrive. But anyway, that is a general outline of what to do about back pain.
And how much does it change with age?
Well, the answer is, as you know, the answer is it depends. Sometimes it doesn't change very much, and sometimes it changes a lot because some people might be chronologically older than their biological age, and vice versa. Some people have a biologically older spine and a younger body. But if I was to take, say, an 80-year-old, and I see some trainers giving them exercises that would be more appropriate for an Olympic weightlifter, I have to shake my head because the primary risk or compromise to that person's health might be falling. That is the number one issue, and yet they're ignoring balance training, footwork training, and these things that allow recovery from a fall, for example. But I'm assuming you want more back-specific kinds of things. Keep walking, for sure, but that requires a balance, hip, core stability, athleticism. I would need a specific case in front of me, I think, to be more specific now.
Okay. Let's talk a little bit about what you just mentioned was one thing, core stability. And I know that term is very familiar to listeners, and yet really to define it. I mean, can you do that for us? Because I'm afraid some of our listeners may have their own interpretation of it, but you being the guru, can you share yours?
Well, your perception on people's misperception of that word is very insightful. To measure core stability, there's only 3 or 4 university laboratories in the world that I know of that actually measure it, and we were one of them at the University of Waterloo. There really isn't a surrogate that you can use. What I do now is, I've been measuring it for 30 years, so I can see fairly quickly whether a person has what we call sufficient stability or not. So let me give you the 3 scientific principles that govern core stability. The first one is this: the body is an articulated linkage. So each segment of our arms and our torso and legs and whatnot form this articulated linkage. If I wanted to move my finger rapidly back and forth, I would have to stiffen my wrist. Otherwise, my wrist would just be floppy. If I wanted to move my elbow very quickly back and forth, I would have to stiffen my shoulder. So do you see how proximal stability, or stabilizing the joint closer to your core, is necessary to liberate or allow athleticism more distally? So the mother of all proximal stability in your body is your core. I'll give you another example of walking and why walking is such a core stability exercise. Imagine you're standing on your left leg and you're swinging your right leg as you're walking. Your right side pelvis is tending to fall down to the ground. You have to use the outside hip musculature on your stance leg to hold your pelvis up so your spine doesn't bend. Is that painting a visual for you?
Oh, yep.
Okay. So you use the hip musculature on your stance leg, but that musculature isn't strong enough if you were carrying a bag of shopping. You now have to use the quadratus lumborum primarily and the oblique muscles of your abdominal wall on the swing leg side to help hold your pelvis up to keep it level to support your spine. So what I'm proving... Okay.
I'm going to stop here for a second. So for listeners, quadratus lumborum in the back, across the lower back, right? The obliques along the side. So you're getting an idea here.
Yeah, okay. It's the right and left side of your torso muscles. Yeah, thank you for picking me up on that medical jargon. But the point is, you need the core to hold your pelvis up. Now, it's very rare that an older person would have a paralyzed quadratus lumborum or one of those muscles, but you see it occasionally in the neurology ward in children's hospitals. When a child loses the ability to activate quadratus lumborum on one side, the thing that they have the greatest difficulty with is walking. Their spine collapses when they stand on the opposite side leg. So it shows you how important core stability is. Without it, you can't even walk. But that's why, people say, what's a great core stability exercise? Well, it's any exercise that creates muscle patterns that creates appropriate stiffness in your core so that you can move your limbs. Well, there's an example from walking, but there's rule number 1. You must achieve proximal stability, which is your core, to allow distal movement, even in something as simple as walking. The next principle is the spine is a flexible column. Now, think of it as a stack of oranges. If you put a book on the top of a stack of oranges, the oranges would fly apart. But if you took that stack of oranges and attached guy wires down and around every single orange, you could put a few books on top and it wouldn't collapse now. Do you know what I mean by, think of the rigging on a ship's mast. So the core musculature acts like rigging on a ship's mast to allow the spine to bear load. So on one hand, we want to dance, we want to have fun, we want to throw a ball with our grandchildren. This all requires spinal movement. So it's wonderful to have a flexible column. But when you bend over to pick up your 5-year-old grandchild or your 8-year-old son or whatever, maybe it's a suitcase off the carousel, you've just arrived in Mexico. The point is, you now had to stiffen that flexible column to avoid injury, and we've measured that as a mechanism. The spine will buckle when it doesn't have appropriate stiffness or stability. So that's scientific principle number 2. So the stabilization exercises have to train the muscles of the torso to play like a well-tuned orchestra to allow movement, but also maintain what we call sufficient stability and robustness so the spine doesn't buckle. The third element of core stability is this. Can you imagine when a person has damaged their knee ligaments, for example? The knee now has micro movements in it that cause pain. So the doctor will do a drawer test on the knee to see if those micro movements are causing pain. We do exactly the same test on people with back pain. We do shearing tests through their spine, and we find the segments or the levels in their spine that are a bit lax because of damage to a disc or a ligament or whatever the case may be. And then we see if those micro movements cause the person's back pain. And then we organize some more core stability to see if immediately the pain is less. And I'll give you an example. In the book, we show several tests. One of them is the heel drop test. So you have the person, and the first instruction is relax your belly. Don't be proud, just let it hang there. And then you go up on your toes and elevate your heels just 2 centimeters, a very small amount, and then just land down on your heels. Now, some people with micro movements causing pain right away will say, oh, yes, that triggered my familiar pain. And then we say, okay. And then I poke my fingers into their abdominal wall, lateral to their navel. So push their fingers in, say, 10 centimeters lateral to each navel, to their navel on both sides. And then I say, push your fingers out. Okay, now they've used their abdominal muscles to push their fingers out. And I say, repeat the heel drop test. More often than not, they will say, oh, my pain is gone. So you just proved that it was the micro movement generating the pain. And now you just proved a strategy that they can now use completely voluntarily to make themselves robust if they think they are going to move suddenly or take a load and take their pain away. But here's the funny thing. A few of the patients will say, oh, when I push my fingers out using my abdominal wall, that increased my pain. So that shows that that person didn't have enough compression ability in their spine, because when you use muscle, it actually costs your spine. So again, it helps the reader converge on the strategy that they need to engineer out the pain in their body. But anyway, there's the three formal parts of core stability and how they can be used to guide the patient out of pain and become robust once again.
Fantastic. Okay, so we're talking core stability and several things. When you said, you're going to organize stability or find a way to actually bring it about in the individual, what you haven't mentioned is anything about forward flexion. So in terms of crunches and sit-ups, you knew that I was going to get to this, right? This is the juicy question. And this is an audience who grew up being told sit-ups and crunches are the way to flatten that belly and to get a good strong core, or if not a six-pack. So is there a definitive answer? Not what is it? Let's say this. Is there a definitive answer to should you do crunches or sit-ups?
Well, oh dear. I'm going to use the word it depends, but I can hone that a lot more if you will allow me to. Okay.
I will.
Generally speaking, there are better exercises. The Canadian military used to have speed sit-ups as part of their annual fitness test, and they noticed that it was causing an increased prevalence of back pain in soldiers. We were the first to measure the mechanics of a sit-up, and it causes the spine to bend throughout its range over and over and over again at a substantial amount of compressive cost. So the muscle activity during a sit-up squeezes the spine. That value that it squeezes the spine by was determined by NIOSH, that's the National Institute of Occupational Safety and Health in the States, that if you apply that compression over and over to the average American, you greatly elevate their chance of developing a disabling back pain. So, and then we've done a fair amount of science on that ourselves. And then the last piece of that, which is we've done it on cadaver spines as well. We've mimicked doing repeated sit-ups, and disc bulges generally occur over time. Now, will this happen in everybody? And the answer is no. We're all different. And the way that we develop stress in our body is a function of our body type. Can you imagine if I had a thin willow branch, just a thin branch? I could bend that willow branch over and over and over again, and it wouldn't break. And it wouldn't break because it doesn't develop stress. It's too thin. But if I take a thicker stick and I bent that stick to the same amount, it would shatter right away, because the stress in a tube is a function of its thickness. So a person who has a very heavy boned frame, a bigger person, actually will create many more stresses in their back doing sit-ups than a very thin, slight person. So there's one of the reasons why people don't understand why one person can do 100 sit-ups every day and not really have a problem, and the next person does a few and they start to develop pain. But let's now go to the question of a curl-up. We've recommended the modified curl-up for years. It's a good way to engage the abdominal wall and train it and keep it flat and develop the six-pack, as you described earlier, as a motivator for many people doing abdominal exercises. But there we engineer out the injury mechanisms. The person lays on their back, they bend one knee, which reduces the neural tension if they have any kind of sciatica or neural tension driving their back pain, for example. They put their hands, palms down, under their lumbar spine to preserve that natural curve, to take as much stress out of the back as they can. And then they slightly lift their head, their shoulders, and their elbows off the ground and hover just about 1 centimeter off the ground. And people will be surprised at how challenging that is to the abdominal core musculature, the front musculature, and yet it is so spine sparing. Now let's take this to the level of evidence of high performance athletics. And I mean, as you know, I've worked with many medaling Olympians, professional athletes, some of the strongest men and women of the world, and some of the fighters. Are you familiar with the fight league, the UFC?
Not very much.
But you know
no.
what it is. It's cage fighters
Yes.
who by
Sure.
tradition in martial arts have grown up doing hundreds of sit-ups every day. That's part of their training. And some of those fellas have been patients of mine, and their career is now over when they're 23 or 24 years of age because their spine is in so much pain after doing those hundreds of sit-ups every day. So instead of, say they were laying on a gym ball, a stability ball, and they were doing curl-ups over the gym ball. All we do is we turn them over and they do the stir the pot on the ball. So you can imagine it's like a plank. Their feet are on the ground, their elbows are on the ball, and they stir small circles with their elbows on the ball. Well, now let's compare the mechanics of injury mechanism and core athleticism. Every sit-up they do, they maybe get about 40% activation of their abdominal wall. So they're training at 40% and they're bending their spine over and over again. When they do stir the pot, they can turn on their abdominal muscles to 100%. It is such a better trainer of the abdominal wall, and the spine load and injury mechanisms are greatly reduced. Then all of a sudden they say, I am now doing things athletically that I could never do before. Avoiding the sit-ups and choosing a better exercise tool made them more injury resilient, less painful, and better athletes.
Perfect. Love that. Yes. And I'm kind of searching here really quickly, trying to give you a number, but I want to let you know, just released a new book, Hot Not Bothered. It's 99 flips for slimmer, trimmer, fitter, faster, and stir the pot is a flip, definitely included in the book. So you'll know that he's also listed as the resource. So yeah, I love that you mentioned that one. So while we're on the subject of a ball, however, I want to ask you this because I know that a lot of the listeners will be thinking, what about crunches on the ball? Is that better or safer? And you say,
if you have back pain, get rid of the ball.
Okay, so I think we have our answer there. Love this. All right, let's talk about factors that increase the risk of back pain. You've alluded to one, and maybe I can come back and ask a question about that. So the thickness of our spine. And I mean, is that easy to gauge for you? I mean, we're really looking at just simply bigger boned, overall bigger people, or we can assume or assess. I know assume is not a great word here, but we can kind of visually estimate they've got a thicker spine, so they would be more at risk than a small framed person.
If you've got enough experience to look at a person, you should be able to look at what's called biiliocrystal width, which is the width of their hip bones, the width of their elbow bones and knee bones, wrist, etc. And that will be a general indicator of the heaviness of their frame. But I should be clear on this now. It's so interesting that I'll just throw a fact out there that you might find interesting. Do you know of a middle linebacker from professional football who can hit a golf ball very far? The answer is no, because their spines are too big and too thick. So that type of spine is made to bear a lot of compressive load. That's how they weight train and take hits in football and all that kind of thing. But by definition, it's a spine that gets more stressed when it's bent and twisted, whereas the archetypical golfer's spine isn't going to last very long in the NFL because that is a more slender spine and it has architectural features that allow it to play magnificent golf and be mobile. But what allows it to do that prevents it from withstanding high compressive loads. So you see these different architectures, they all have different advantages and disadvantages in terms of performance and resilience to specific things. So I'll just throw that out to start.
I think that you've just given my significant other a get out of jail card for his golf.
Can I mention something that will tie this together, and that is the biological tipping point?
Yes, please.
Every biological system has a tipping point. So I know you have expertise in nutrition and that kind of thing. Think of the biology of the body requiring a certain vitamin or nutrient. When it's deficient, it's sick. And then you give a certain amount of the vitamin, which is very therapeutic. It's enhancing of health to a tipping point. And then when the vitamin becomes excessive, it now becomes a poison. It's past the tipping point. So load to a musculoskeletal system also has a tipping point. And below the tipping point, you get optimal health, minimal pain, no dysfunction, and all that kind of thing. So the goal of what we're all trying to achieve is to extend our tipping point, but don't cross it. That's the magic of it all. Keep it as large as we want it to be. But now we have another little consideration. There are some people who work so hard and become so athletic when they're younger, they use up their body and put up so much wear and tear on it that the tipping point really starts to crash down faster in later years. So I know there's this movement now, it's very popular on the internet, that you should be more fit now and you're going to be a more fit senior. I think if you spent a little bit of time in the joint replacement sections of the hospitals, you'll see that that's actually the opposite. There aren't too many great Olympians who are masters, world masters level athletes later on. You'll find that quite often it's the people who found athleticism later in their life. So again, this biological tipping point, it's better to be a little more moderate through your life, and that will extend that tipping point for more years. But anyway, that certainly is true with backs, and by default, I mean, obviously I have to deal with hips and some of these other related parts.
Yeah, super good point. Yeah, I really like that. And I love the analogy of tipping point. Great for the audience to hear. Other factors, and you know, I have a feeling you've got a juicy tip or two to share about risk factors.
Okay, well, if I could list the
this is the X-rated section, right?
Well, sure. The top five. Number one is don't violate the tipping point. You'll be a healthier person. Number two is move well. So a person who has poor posture and poor movement habits are creating stress risers in their body that eventually over time will cross the tipping point. So move well, and certainly the book guides that in the spine hygiene section. The third one is choose.
Stu, can I interrupt you just for a second? And I'm going to ask a very leading question. Listeners, you all know I have a background as a medical exercise specialist, a personal trainer, and favor the personal training injury. But Stu, in your opinion, when you say move well, how many or what percent of people could be served well with a custom exercise program?
Well, I mean, I was going to be flip and say everybody.
Yeah. Okay. Even better than I was hoping.
Even myself. I
know somebody.
Well, you know, Alan Cosgrove, who's quite a famous trainer in Los Angeles, I heard him give a speech at Perform Better a little while ago, which is in a meeting of elite coaches. And he said, now all of you in this room are movement specialists. How many of you have an expert trainer and movement coach? And very few of them put up their hand. And I was one of them. And yet every time I work with an outstanding trainer, I learn a little bit more about myself. And I'm going to say something that will be very hard hitting now, but there's a rainbow at the end. More than half of the patients I see have been created by trainers. That's a bit of an indictment. Now, on the other flip side, consider this. Every single health system in the human body depends on movement. Number one, to be healthy. Think of every single one. Number one, it requires good movement. So by default, the trainer has the ability to make the biggest impact on that person's lifelong health by achieving good movement, sparing their joints, fueling the system appropriately, et cetera, et cetera, et cetera. It's so important to get it right. So that's the good side of it. And there are outstanding trainers. Case in point, I'm speaking with one, and the responsibility that we all carry is enormous, and it's overlooked by the medical profession because most of the patients coming in there, think of all of the diseases of choice: people not moving enough, having all sorts of blood sugar issue, cardiac issues, musculoskeletal disorders, and then the ones who think, they're 40 years old now. They go to the gym and some trainer's training them like an Olympic lifter. It just doesn't make sense. And instead of building their body and respecting that tipping point, they're actually crossing it and tearing it down. So anyway, the role of the trainer is absolutely paramount. And I can't emphasize that more strongly enough.
Thank you. Okay, so where I disrupted you. All right, so don't violate the tipping point.
Back pain.
Move well.
Yeah, don't sit too much and keep walking. You have to have several walks a day for a healthy back. Now, the juicy bit that you want to get to, I'll preempt the introduction by stating this. Every primary care clinician will tell you that they have couples coming to them who say, the last time we had sex, we knackered our backs. We are now fearful and we're celibate. There are no guidelines that exist to guide doctors and physios to tell them what to say. So we recognized this, and about 5 years ago, and this was a huge project through the university. You can imagine the ethical concerns and whatnot, but we did the first study in history of people having sex, different styles, and we were measuring joint loads, muscle activation patterns, and all this sort of thing to figure out, let's say a person had knee replacement or hip replacement, or they hurt their back when they bend over and garden, for example. That's forward flexion. Now, if that hurts your back, there are certain styles and positions you should avoid for sex, but there are others that should be perfectly fine. If reaching up overhead and changing a light bulb and going for a walk for half a kilometer cause back pain, that's another subcategory. And you should be avoiding certain positions and movements, but you should be perfectly fine and resilient for others. So we were able to create this atlas, and it's now in the process of being published in several medical journals to guide clinicians. But in the last chapter of Back Mechanic, we give a little short form of it to once again empower people and take away all this needless fear and pain.
I love that. I love it. And it's such an important topic. I think listeners, you can appreciate this, whether or not you're going to write in about this one. This is notoriously a topic of conversation, whether we're talking about libido, or we're talking about avoiding pain, avoiding injury. not knowing what to do or whether you should, it's a topic we don't bring up necessarily with our doctors. We're not comfortable. And then we're probably not also talking and venting about this necessarily to our girlfriends. But the challenge is we may also not be even talking about it with our partner. So, intimacy being such a crucial part of wellness for life. I'm so glad you brought it up. So thanks for doing that.
You're welcome.
Okay. And, I was dying to ask, complete with illustrations in the book?
Well, there are some illustrations in the book. Yes, obviously the atlas is a lot more comprehensive.
Okay. So as we wrap up, I have a feeling we could go on and on. There is one final question I want to ask you, and then I'll ask you the real kicker that I ask all. But we talked about really sit-ups and crunches, and you can tell this is heavy on my mind because it's really a topic of conversation that I get into very frequently. We talked about the health of the spine and the risk to the spine and whether it's increasing the risk of back pain potentially for someone or continuing to contribute to back pain. But what if we talk about the opposite? Do you feel like, can you address this? What about sit-ups and crunches and their effectiveness for getting the result that we want in the musculature as opposed to other exercises out there?
So we're talking purely aesthetics now? Okay, yes. Well, there's a position paper put out by the NSCA, National Strength and Conditioning Association, and it's co-authored by Dr. Brad Schoenfeld and myself. He's one of the editors of the Strength Journal, as you know, and it was motivated exactly from the question that you just mentioned. So Brad, Dr. Schoenfeld, has written books on bodybuilding, hypertrophy. He is seen as a muscle and an appearance specialist. I was the injury and function specialist. Of course, any exercise, as I mentioned earlier, is nothing more than a tool. And it is a tool to achieve a specific objective. So if your objective is to have a good-looking figure and some abdominal definition, if someone wants a six-pack, let's say, and no real performance and less pain, why take the risk? Choose the tool with the best risk-reward ratio, which would be the family of curl-ups as we described, and then moving on to planks if you want more challenge. But that's where that position paper from the NSCA started. And then we went through the spectrum of more let's get into bodybuilding, and people really want hypertrophied washboard abdominals. You can do the sit-up, but that's the juice isn't worth the squeeze when you get into the science of it. But if you did partial curl-ups now, the length change in the rectus and obliques occurs, and it will stimulate a little more hypertrophy. So there you go. It's a spectrum, and choose the tool with the best risk reward for your purpose.
Great advice. Thanks so much. And I'm very familiar with that paper. I believe that's a resource as well in Hot Not Bothered. So shameless plug again. All right. Now, the question of the day. So for every guest, as we wrap up, is there a question that you wish I would have asked?
Not that I can think of. You did a fantastic job. I think I could just sit and listen to you all day.
Well, it's good for a nap anyway, right?
Anyway, I'm feeling very comfortable now, Deborah. I hope you are as well.
I am, and I thank you for all the little tidbits. And I'd like to just leave the audience with your book. Again, Back Mechanic was actually meant for them. So, although Dr. McGill writes a lot for me, for my colleagues, and for academia, this one's intended for you. So it's written specifically for you for your use. Where's the best place for them to get that?
Well,
Dr.
it depends
McGill?
on where they live. It's available worldwide on many different websites, but our own website, which is backfitpro.com, and it's just spelt as it sounds, backfitpro.com.
Okay.
When they click on the book, they will see different maps, and if they live in the USA, it shows them where to click to get it at the cheapest shipping rate. But BackFit Pro ships worldwide. But there's a place for European orders, and all over the world. And they'll see our other books as well. Can I just take 30 seconds and just to mention that I never thought 10 years ago I would ever write a book like Back Mechanic. My first book was a very heavy clinical textbook for clinicians. And it was some very savvy lay public people who read the book and said, wow, this has been so helpful. No one has ever shown us before how to assess back pain, and we did it on ourselves, and we were able to create patterns that took our pain away. Why don't you write a book that's understandable for the lay public? Take out the medical jargon. So that's where Back Mechanic came from. But there will be some people who want the heavier clinical texts.
Fantastic. Okay.
Or Amazon. Everybody you can go to any Amazon as well. Amazon.com.ca.uk. You can get the book there as well. Oh, and may I also mention, I think we're up to 13 different languages at the moment.
Wow. Which is going to be very helpful for some of our listeners. So backfitpro.com, that link will be right in the show notes. So those of you who are walking or weightlifting while you're listening, or potentially you're driving, it'll be there waiting for you. So Dr. McGill, thanks so much for being here.
Deborah, thanks so much for having me. It's been a lot of fun. Thank you.
And listeners, if you have a question that I did not ask, leave it below the show link at flipping50.com. I love hearing from you. And if this episode was helpful, please leave a rating in iTunes and then share it with a friend. Surround yourself with a supportive community of women on the same journey. To get the most from this week's episode, check out today's show notes at flipping50.com/podcast, where you'll find the juicy free link to Dr. McGill's book and the resources we mentioned on the show. And let's start flipping 50 together.